Hello and welcome. Welcome, good morning, good afternoon, good evening to everyone. And welcome to the Leica's Clinical Online Symposium. So my name is Elvin. I'm the product manager for the ophthalmology imaging platform at Leica. And we are very fortunate today to be joined by two distinguished speakers, Professor John Mehta from Singapore and Professor Luigi Fontana from Italy. So today's discussion topic is going to be a clinical symposium on corneal surgery, and more importantly, how to improve the surgical outcomes in corneal surgery with the guidance of intraoperative OCT. So some tips before we start and some information. If you're viewing through your tabs and you notice a slow or laggy connection, we advise you to close your other programs, to close your browsers to make use of your full bandwidth. And at any point of time, if you encounter any difficulties, you require some help, please feel free to reach out to the help button in your screen at any point of time. And throughout the session, you're welcome and highly encouraged to submit questions through the Q&A button under the presentation window. So any technical questions, please reach out to us and we will address this immediately. For resources-wise, we also have information regarding this webinar, and we also have information regarding our product portfolio at your disposal on the screen as well. So let's jump right to that. So we've got quite a packed agenda today, and we are quite excited to have all of you with us. And agenda-wise, we've got a quick brief on the intraoperative OCT features by me. But again, the main focus of this talk is by Professor Fontana and Professor John Mehta. So we'll really emphasize on their clinical experience and for them to share their wisdom, their knowledge, as well as their experience using Leica's OCT product. And we'll end it off with a Q&A session by addressing the questions which you have posted through the window as well. So a quick introduction on our speakers. So we are again very fortunate and very glad to have Professor Luigi Fontana here with us. So Professor Fontana is specialization is in cataract surgery, glaucoma surgery, and corneal transplant. He's a lecturer at the University of Bologna. Following his residency program in ophthalmology at the university, he has also completed a fellowship in visual science at the Institute of Ophthalmology in UCL. He has a fellowship in glaucoma in Mossfield London Hospital, as well as a fellowship in cornea in Mossfield as well. He has more than 20 years of experience in the treatments of complex anterior segment diseases, including cornea, ocular surface, cataract, and glaucoma. And he has also founded the National Eye Bank for 10 years, Emilia Romagna. So his research encompasses more than 200 articles, books, chapters, and books that are focusing mainly on new surgical keratoplasty techniques. He is also a former and current board member of several scientific societies, including the Corneal Society, European Corneal Society, and the Society Italia Trepaneo di Cornea. So thank you, Professor Fontana, for joining us today. We're also very fortunate to bring on board Professor John Mehta. So Professor John Mehta is the head of the corneal services in the Singapore National Eye Centre. He's also the head of the Tissue Engineering and Cell Therapy Group in the Singapore Eye Research Institute, and a professor with the Duke NUS program. He has also been named the Professor of Clinical Innovation at both institutes, the Director of Education, Seeing Health Transplant, and the Deputy Director at the Singapore Eye Research Institute. He has published more than 390 peer-reviewed papers, 20 book chapters, citations-wise more than 9,000, been invited to more than 250 symposiums, lectures, and with over 50 national and international awards. His research work has 15 patents, 5 of which has been commercialized and licensed. And he also leads a clinical service and runs a research program comprising of clinical and translation studies. So his work now is focused on corneal transplantation, femtosecond laser technology, corneal imaging, corneal infections, corneal refractive surgery, prosthetic surgery, and corneal genetics. Thank you, Professor John, for joining us today. So just a few insights. So I'll spend a couple of minutes explaining our products. And I think the main aim of this webinar, as I mentioned earlier, is for the professors to share their clinical experience and their clinical knowledge with us. So very exciting here. Just a few words about the intraoperative OCT in the Proveo 8 system. The main focus and the main value we like to bring is really about bringing greater insights to be able to see subsurface details at the cellular level. And this is really critical. I think you'll see some of the videos presented later by the professors. And also to have immediate confirmation. And this is quite critical. So the Leica EnFocus allows you to basically scan across the z-axis, across the entire microscope's magnification range. So you're able to see an immediate visual confirmation, regardless of which plane you're working on. And because it's integrated, it's now fully integrated into your microscope. So in terms of workflow, you can switch and record effortlessly with the assurance that you have always OCT imaging available in a single package. So again, resources on this are available at any point of time if you need it on your browser as well. And the key emphasis here I would like to bring across is you get immediate confirmation with a real-time display of 30 frames per second. So you're basically able to verify the adherence of donor tissues in your corneal transplant, and you're able to instantly adapt your surgical plan if the OCT reveals a complication. You can also easily review, so in the bottom of the screen, you can easily review and play back the scans. And quite interestingly, there's a caliper function, and the caliper function allows you to measure the thickness of your graft and measure the thickness of your cut as well during the procedures. So jumping right in, just 3 more slides, and I'd like to pass on the time to our speakers after this. But quite important, and I think it's very interesting. If you observe the resolution of the OCT in the OR, you'll notice that the resolution is the sharpest in the market. We have the resolution to a cellular level, and you're basically seeing up to 2.4 micrometers. And this allows you to have greater confidence in your clinical decision as well. Lateral resolution wise, you can read the details here. I won't jump right in. I also want to emphasize on the end-fast view and the depth of the A-scan. So this allows you to visualize the full anterior chamber with less movement by the surgeon. And the end-fast view basically allows you to see the entire image of your cornea. And I'll show you some pictures later as well. High density wise, we are able to go up to 500 B-scans. And in comparison with competitors in the market, with 5 scans, this allows you to see between the gaps. So you are able to see your entire graph and to check for adherence to see in greater details. Field of view wise, we have a 20 by 20 mm across the microscope magnification. And this is really critical because it allows you to see the white to white in the cornea. And it also allows you to scan for the entire range of the microscope in the z-axis while you're working on a single plane. So it's not restricted to the plane you're working on. In terms of image acquisition, we are able to get a less than 5-second refresh rate on the cornea. So you're able to find the OCT image, and this auto-locates, so it increases your workflow efficiency. For scan management, so we found this quite interesting. We have different programs here. We have a crosshair, we have a rectangular scan, and we have a radial scan. So I just want to emphasize, a lot of retinal surgeons we spoke to, they tend to prefer scanning from top to bottom or bottom to top, or across left to right. For corneal transplant, we found that the best approach is to do a radial scan, and this allows you to sweep 360 degrees across, and you can verify the adherence of the grafts, as you can see from here, and you are also able to image the graft transplant under dye. For Z tracking wise, you can see we're tracking the Z-axis, and this basically reduces the user movements. And we also provide auto optimization functions. So it allows you to auto locate the features of interest, to brighten it automatically, and to compensate for noise. And this allows you to get the best image at all times. So the last slide here, and I think quite key features, is that you're able to display different options. You have the option of 50-50. We have the OCT and the surgical image on screen at one single glance. You can also customize this to just the camera image or just the OCT image and customize this for different monitors. You can also control this with a touch interface, and you can see from here, even with a drape and glove, the surgeons assistants are able to manipulate and adjust the multi-screen functions either by your handles, your foot switch, or by touching the screen directly through the sterile grips. All right, so without further ado, I'd like to pass on the time to Professor Fontana to take us through intraoperative OCT and laminar keratoplasty. Prof, over to you, please. Thank you.
Thank you very much, Alvin, for your very kind introduction. The topic I'm going to cover is what is the use and the advantage of the OCT in lamellar keratoplasty. Now, we know that the time of penetrating keratoplasty is almost over. We are now able to transplant selectively the epithelium, the Baumann layer, the stroma at different depth, the descemet membrane together with the endothelium and the endothelial cells themselves. So we're going to start with the selective stroma replacement. As you know, the indication is potentially in every case where the endothelium is healthy and the stroma is diseased. Now, we know that we can start the video. The most famous and worldwide used technique for stroma transplantation is the big bubble technique developed by Mohammed Anwar that I'm very briefly describing in this picture. The key is to create a detachment by a pneumodissection by injection of air in the deep stroma between the posterior stroma and the endothelium. And this allows to selectively dissect and remove the stroma, for example, in this case of keratoconus, and isolate the descemet membrane together with the endothelium and replace the stroma with the donor stroma. And this is currently the quickest and the most worldwide used technique for DLK for keratoconus patients and also for the treatment of other stromal diseases. Now, what could be the use and advantage of a new technique? Now, we know that the key point of this technique is where to inject air. Air should be injected very much in the stroma, close to what we know now is the Duas layer or the pre-descemet layer, in order to achieve a dissection separation between the posterior stroma and the descemet membrane and endothelium together with the pre-descemet membrane. Now, in order to achieve that, how the OCT can help in order to perform a DLK procedure. Now, first of all, the OCT may be helpful for assess preoperatively the corneal thickness on the operating table in order to establish the size of trephination and the depth of trephination. Then the OCT may be helpful, and I'm going to show this, in order to guide the cannula insertion right close to the pre-descemet membrane or Duas layer in order to more easily achieve a big bubble formation. And then evaluate the cannula position inside the stroma, evaluate the big bubble extension once you have achieved it, and evaluate the completeness of the stroma removal and the graft donor graft position. Now let's see this. This is a trephination of the cornea, and you can see that the OCT may help you to see how deep the trephination was created, and this is particularly useful if you do not use a guided trephine. Now let's see in a model eye, start the video please, how this thing helps. Of course, this is a kind of a wet lab, easier to show this in a wet lab set. I at the moment using calipers to assess preoperatively the thickness of the cornea. Then I'm refining the cornea partial thickness fairly superficially as I wanted in this case. And now I can see that with the calipers, I can judge exactly the depth of the trephination. In this case is 330 microns. Then I decided to increase the trephination depth to 450 And so I refine again exactly in the same position as I refined in the first case. And now I remeasure again the depth of the trephination, and you can see that the trephination depth has increased now to almost 490 microns, which is not good enough, not deep enough as I wanted. So I increase again the depth of the trephination, right in this case up to 550, which corresponds more or less to 90% of the corneal depth. As you can see, I can also measure the inclination of the trephination in order to see whether the trephination was actually carried out at 90 degrees or, as in this case, 80 degrees. Then what is the second step, which is the most important step in the big bubble procedure, is to insert a cannula. Nowadays we do not use needles anymore, we use cannulas, blunt tip cannulas, right at the level of the pre-decimate layer or duas layer, so at very much at kind of 90% of the stromal thickness. As you can see, this is a paper that was published a while ago, showing that if the cannula is placed very much in the stromal depth, the chances of getting a big bubble formation is very high, whereas if you place your cannula not deep enough in the stroma, as in this case 160 micron from the decimate membrane, chances of getting a big bubble are far less. Now let's see how it works with the intraoperative OCT. As you can see here, video please, you can see that I've done a partial thickness trephination, then I'm using a pointed dissector in order to create a tunnel in the stroma. And I purposely wanted to create this tunnel not deep enough as I wanted, more superficially. So I measure it, and I decided then to increase the cutting the trephination manually with a blade in order to reinsert the peak, this sector, more deeply in the stroma. As I can see that I can see exactly where the pointed knife is, and I measured it that is less than 100 microns from the decimate membrane. So at this point I insert the cannula, and I can follow the cannula exactly along the track, and I can see that it is very close to the pre-decimate layer, almost near to trephination. And then at this time I inject air, and you can see that I get a formation of a large bubble, which is exactly what I wanted. And this is just to confirm in this donor eye that the bubble was formed quite large, exactly in the way that is that I wanted to create. So in brief, it is possible, as I showed you, to assess exactly the position of your instruments inside the stroma. Let's move to the next slide. Let's talk about selective stroma replacement, endothelial replacement. What do we mean for that? Endothelial keratoplasty in the forms of DSEC or a DMEC, and is performed in all cases where the corneal endothelium is diseased while the stroma is healthy. And now we know that we're using mostly two forms of endothelial keratoplasty, which is DSEC in the form of a standard DSEC of ultra-thin DSEC, and DMEC, which is the one that is more and more performed worldwide. Now, with ultra-thin DSEC, the trick and the difficulty is to make a donor cornea which is evenly very thin across the length of the cut. And you can see here in this figure, this is a perfect cut where the thickness is overall less than 100 microns. And whereas here in the bottom picture, you can see there are areas of this cut where the remaining stroma is thicker and other area where it is thinner. And this is exactly what we possibly do not want to implant in a patient eye. And let's see how the OCT may help. Video, please. preoperatively, we can measure with the calipers the thickness of the cornea. In this case is a donor cornea, so it's more thick than in the real life. And we can measure the thickness of the cornea in different points. As you can see here in the center is more than 550. And so we decided to use a certain blade in order to cut the donor graft. And so we use a 450 microns head for a microkeratome. And so we remove a big chunk of stroma, and this is what we get. And this is something that you can see in real life and measure it. So we measure with the calipers what is remaining thickness of the graft, and is just less than 100 microns in the center and a bit more in the periphery, as it has to be, can be differently. And so this is a great advantage, because the surgeon knows exactly what is the thickness of the graft that he is going to insert inside the patient eye. And so let's move to the implantation. What is the advantage of using an OCT? I can show in this video where I'm implanting a graft in a rather difficult eye. This is a total corneal decompensation in a patient who had a previous trabeculectomy, and so it's difficult actually to see through the cornea, but it's possible to remove the descemet membrane and endothelium of the patient. Particularly with the help of the OCT, you may visualize the descemet membrane more easily, and so you are more sure of removing the entire descemet membrane completely, as you can see in this case. And during the implantation, as I'm doing right now using the pull-through technique, you can see exactly the graft unrolling and unfolding inside the eye, and as you can see right now, and you can see the position of the graft. And once you're sure of the position of the graft, you're able to inject air or gas, as in this case, and control the adhesion between the graft and the posterior stroma. And as you can see, the adhesion now is achieved and is very much homogeneous, and there are just little tiny areas of detachment, but this will go away during the first day, and you are sure of the perfect adhesion between the elements that you want to transplant. And this is with a continuous scan, you can check through the cornea 360 degrees the adhesion between the graft and the host. Now let's move to DMEC. Now DMEC is a further development of endothelial keratoplasty. Is the one that probably allows the best results in terms of visual acuity for the patient. The difficulty is to insert the graft and displace the graft in the correct way in order of not implanting the graft upside down, but rather implant the graft right side up. And we know that the grafts tend to coils inwards, okay, with the endothelial layers sitting outside of this coil. So it's very important to recognize, and this is the OCT may help a lot, the position of the grafts by the coiling, okay? And so being sure of the right orientation of the graft as you managing the procedure. Now let's see exactly what we mean. Let's start the video. And we can see that I'm just removing the recipient endothelium and descemet membrane. And it's possible to check, as in this case, if I remove it completely. And you see here some remnants of the descemet membrane. They are perfectly visualized with the OCT. And I want to remove those in order to have a perfect adhesion between the donor and the host. Now I'm injecting the donor with a glass injector, and this is done also under control of the OCT, and you immediately see through the OCT the correct position of the graft. And you see the coiling inward of the graft as I wanted it to be, meaning that the graft is correctly positioned right side up. So I'm just unfolding the graft, and once the graft is completely unfolded, and it takes sometimes a few strokes before the graft is totally unfolded, I'm still checking of the coiling, the correct coiling of the graft, right until the very end. And here I can see that I unfolded the graft, but I'm still seeing the edges of the graft being coiling in the upside, in the correct position, right side up, so coiling inward. Now that I'm sure of the correct position of the graft, I inject air together with gas, and you see immediately the adhesion between the posterior surface of the stroma and the graft, and checking for area of little tiny detachment that I may want to wait and see. So what is the advantage of the OCT in the procedure of DMEC? Here is the correct position of the graft during the unfolding, so the graft is coiling inward, and with OCT I'm able to follow the correct orientation of the graft right until the very end of the procedure, when you inject your air, when you inject your gas. Whereas if you should notice that the graft is orientated upside down, as you can see here in this picture, then you know that you have to work again to try to capsize and the graft and put it in the correct order position. So again, another aid, another advantage for the surgeon in order to facilitate the orientation throughout the procedure. This is not just helpful only for the experienced surgeon, but I believe that it's particularly helpful for the less experienced surgeon, because any extra help may make the difference, particularly when you are in the first early stages of your learning curve, where you may need extra help to make sure that the procedure is correctly performed. So thank you very much, and I hand it over to Prof. Jod Mehta, and let's see eventually for each other for some questions. Thank you.
Thank you, Prof.
Great. Thanks, Luigi. Thanks, Alvin. Got my slides. Okay, my slides on? Yeah. Okay, so I'm going to be talking about DMEC and some complicated DSEC cases and the use of intraoperative OCT. These are my financial disclosures. So we'll talk about a little bit about switching on to basically doing DMEC from DSEC, some tips and some advantages of basically using the intraoperative OCT, and showing the use in some complicated cases to see how it can help you perform this surgery. So Luigi has basically talked about this, about the overall scheme about going from penetrating keratoplasty to endothelial keratoplasty, either in the form of DSEC or basically DMEC itself. And the reason why everyone is basically changing to try to do DMEC is given, like in this example here, two of my patients. On the right eye, the patient sees quite well. It took 12 months to get that pretty good endothelial cell loss of about 11% at 1 year. On the left-hand side, the patient sees the same visual acuity, but it only took about a month to get this level of vision with a slightly basically higher endothelial cell loss. I mean, there's a DMEC on the left-hand side and a DSEC on the right-hand side. And basically, I think there's no doubt that you do get faster visual rehabilitation with DMEC compared to DSEC. You get less aberrations on the posterior corneal surface, so patients like the vision because it feels more real. Certainly, you get less rejection, but there is probably slightly higher endothelial cell loss compared to the best DSEC techniques, and certainly a slightly higher rate of rebubbling compared to when you're basically doing DSEC. If you look at comparative eye studies, when one eye is basically DSEC, one eye is basically DMEC, you will see in the same patients that I showed you in my example that the patients do see better vision in the DMEC eyes compared to basically the DSEC eyes itself. And in the literature from Eye Bank Association of America, you'll see the number of DMEC cases has been increasing, 3.2% in 2013, up to almost 43% up into 2019. If you graphically see this on the left-hand side, this is the EBA data up to 2019. What you'll see is that the number of cases in the US and DSEC have basically been coming down, and DMEC is basically on the rise up to 28%, and that's up to about 40%. So it's really DSEC is on the way down with DMEC on the rise. I started doing DMEC about 2014, 2015, and you can see still DSEC was my major procedure, but DMEC cases increasing over the following 2 years. However, in 2017, 2018, there was a big shift in the technique that I shifted to, and that really increased the DMEC surgical numbers, because I felt that I could only plateau at about 26% with DMEC doing the more straightforward cases, and I'm still doing DSEC for the more complicated cases. Some cases I still think require you to basically do DSEC. These are patients with certainly severe corneal edema, patients who require extensive iris reconstruction, or patients who have extensive stromal scarring, and certainly you have to be careful with children. Like in this case at the bottom right hand side over here, this is a young child, 11-year-old, had a PK done at 1 year old of age, and this graft lasted quite well until he was 9. And then I basically did a DSEC for him underneath the previous PK. Many times in these children, they find it very difficult to posture. So of course, I think doing a DSEC was a better option than doing a DMEC. And then I will often suture the graft in this situation as well to keep it intact. Other cases that require extensive manipulation of the iris, you worry about getting a lot of bleeding during the time of surgery. And in that case, you may think that you want to basically do a DSEC as opposed to basically doing a DMEC procedure, because often there's a lot of blood around the AC. If you inject the graft inside the eye, the DMEC can actually stick to the fibrin glue, and you can see on the right hand side over here, we're suturing the DSEC back into the back end of the PK case in this child. Ideally, when you're starting DMEC, I'd start with an easier procedure, pseudophakic bullous keratopathy, or a Fuchs case that is decompensated, that is pseudophakic. Try to avoid doing triple procedures to start with. PI-induced Descemet's bullous keratopathy is quite a nice case to do as well, because the AC is generally a little bit shallower, and the Descemet's is often not so scarred. And we see a lot of, reasonable amount of CMV endotheliitis in Asia. So I like to do DMEC in these cases because it allows you to use less immunosuppressive medication afterwards. The reason why I think there's a barrier to adoption to basically doing a DMEC is actually trying to harvest the graft. I mean, it can be difficult to be worthwhile practicing in a wet lab. Ideally, get an experienced mentor to basically help you. DSEC basically needs a microkeratome, but of course, even doing nano-thin DSEC can be a little bit more tricky to cut with the microkeratome, and there is a slightly higher rate of loss of tissue in DMEC. But I can tell you, I taught the Eye Bank in our place to do DMEC preparation about 3 years ago, and they have a complication rate of less than 1%, and it's all basically done by technicians with respect to the stripping, and the different techniques that you can teach your Eye Bank. So how do you get basically, if you're comfortable doing DSEC, to basically doing DMEC? So there's two ways that basically you can do this. One is basically using an endothelial out procedure, where you can use any of the injectors, goiter, injector, DORC, or IOL shooter, or modified Jones tube is very popular in the United States, or essentially use an endothelial in technique where the endothelium is on the inside. And this is essentially very similar to the pull-through technique that we use for DSEC, but we're basically using this for DMEC. And you can use an IOL cartridge. There's an endoglide for DMEC, which I will show you, and Busin also has a technique using a Busin glide. But these are all essentially the two different ways of getting from DSEC to basically DMEC itself. This shows you the differences of the technique. With the endothelial out technique, normally I just pour the donor cornea into a fluid reservoir, and this is sucked up into a glass tube. With the endothelium in technique, I gently flip over the graft. Now the graft has a tendency to flip on the endothelium out, so you have to push it the other way so the endothelium's on the inside and make it into like a taco over here itself. And this is one of the advantages of using OCT over here. You can ensure you have a right amount of fluid, and then this is loaded up into a cartridge. In this example over here, it's loading up into the endoglide, but you can load it up into a IOL basically cartridge as well. This is a big difference between the two techniques, between endothelium in and basically endothelium out, where endothelium out is sucked into basically a glass tube. The insertion is different. The insertion on the right hand side, you'll see with the endothelial in technique, this is very similar to a pull-through technique, but these are using my 27 gauge forceps. You pull the DMEC inside the eye, while endothelium out, you inject the graft endothelium on the outside into the anterior chamber, and then you have to tap it to open up the graft. With the endothelial in technique, you pull the graft inside the eye, and it will open up in its natural way with the endothelium on the posterior surface, okay? So it requires left manipulation inside the anterior chamber because the graft naturally wants to open with endothelium on the outside. So you're just allowing the graft to open basically by itself. The AC maintainer I use on the right-hand side over here is special ACT maintainer, has 2 ports, so it allows you to control the fluid inside the eye. And just by holding the forceps, the procedure is already over. You've already got a bubble underneath the eye, and then you can expand basically the bubble itself. So you can use intraoperative OCT to really help you with the preparation of the graft. This is using the trephination stage, and often when you trephine the DMEC tissue, because it's so thin, you will see that the edge of the DMEC tissue actually goes inside the holes of the trephine itself. You can see this around the edge over here when we use this radial scan going all the way around. And the key thing is that when you're doing the trephination of the tissue, you want a little bit of fluid, but you don't want to have too much fluid. If you have too much fluid on the donor corneal tissue, then what happens is there's a tendency for the graft to basically go into a stroll. So understanding how much fluid to have on the tissue takes a little bit of experience. You can see the fluid level is just above the decimates. Well, you can see it on the OCT over here. And this is exactly the amount of fluid to basically to have itself. And that tells you that your endothelial cells are basically being protected, but it's not too much fluid that it's going to basically put this into a scroll, which then can basically be difficult to open. Once I basically freed up the graft from all the edges, so you can see I'm lifting up the Descemet's membrane side of the graft to make sure it's free from all the edges of the trephine. Sometimes what happens is you can see when you trephine, the edges of the DMEC tissue go actually into the trephination edge, so it's basically worthwhile doing this. Then I will stain the tissue as I use membrane Bluetooth for my staining. And it's important when you're using the staining, you stain underneath the graft. So this will again help you, you can see on the OCT, to see how much fluid in staining. You can see the fluid has gone underneath the graft itself. So I know I'll get a very nice blue when I basically keep this for a minute and then wash this away. So once you basically it's stained for a minute, then you basically wash the graft away, and then you get a very nice dark blue color, which is useful, especially when you're doing complicated cases when the view cannot be so clear as well. Okay. Oops. Okay, so this is just showing you some tips from over there itself. So basically using the radial scan, which is the scan I prefer, it allows you to look all the way around the graft. You can see the graft sometimes gets caught in the edge of the trephination margin, and because this is a DMEC, it's important that basically you flip out these edges itself to allow to make sure the graft is basically freed all the way around. This is just showing you basically when it's free, and then once you've got the fluid level correct, you can then flip over the graft on top of each other itself, and the fluid level there will stop the endothelial side to endothelial side touching. We did do studies in the past looking at putting viscoelastic there, but it didn't seem to make any difference, so now I don't really use any viscoelastic using this technique. And now you can see once you've gone round, whether you can go with a Kelman or with this DMEC stripper, you can see that all the edges of the graft are free, and you can see the fluid level very clearly there on the OCT, so you know you've got just about the right amount of basically fluid. When you're doing the staining, as I mentioned, it's important to go underneath the graft to really get that nice blue color. Otherwise, you're just staining the endothelial surface and will give you a very basically pale blue color itself. And when you wash the dye out underneath the graft, it's important that you basically ensure that you're basically washing out with BSS. Keep it basically there for a minute. Again, you don't want to have too much fluid because the graft will basically go into a scroll basically otherwise. Okay, so once we've got the graft basically stained, you're going to basically then go into basically a fold. Now you can see that I put a little marker over here, which is what we call an asymmetric triangle on the right hand side. This ensures that I will be able to tell my graft orientation because there's an oblique side and a straight side. So the oblique side is on the right hand side, so when it goes into the eye, it's going to basically flip on the left hand side, so it tells me the orientation is correct. Then I simply just lift up the one leaf of the end of the DMEC tissue, and I gently fold it over, and you can see on the OCT that I've got fluid between the two leaves of the graft of the end of the Descemet's membrane, so they basically will not touch each other when I put the endothelium on the surface. And this is what a lot of people find a little bit tricky on how much basically fluid to put in. If you put too much fluid, then you can't basically fold it up like this, because the tendency for the graft is always to be on the endothelium on the outside. If you don't have enough fluid, then of course you're going to get endothelial to endothelial touch, which is what obviously you want to basically avoid. And you can see on the OCT there's a little layer of fluid between the two endothelial leaves of this basically graft. So once you fold this little basically taco fold, you can basically get ready to load this up either into an IOL cartridge, or this is going to go into the new EndoGlide DMEC, which goes through a 2.6mm incision. So this is basically ready to go. Then what we do is we will basically transfer this, and you can see on the OCT where there's basically fluid. So this is transferred into the endoglide, and then I normally basically pull this through. This is using a pair of 23 gauge forceps. There are some 27 gauge forceps coming soon as well, that you'll be able to grab the graft and you can pull this straight into the cartridge. But you can also do this into an IOL basically cartridge as well. Okay, so this is just showing you it's important to remove the excess fluid. You will not be able to flip the graft over, because remember, the graft always has a tendency to fold on the endothelium on the out, and now you want the endothelium on the inside to basically protect this itself. And then you flip over one edge to get into this trifold configuration, and then basically on the other edge, and you can see on the OCT nicely that there's enough fluid there to protect basically the endothelium. So the graft insertion, this is done through a 2.6mm incision. So this is quite simple. You basically put it inside the eye, and normally have a pre-placed suture, inferior basically PI, and this is a double port AC maintainer. You can see the fluid is coming out from the edges of the AC maintainer, not the front side. And then you come across with 27 gauge forceps. You can basically grab the tissue and you can basically pull this inside the eye itself. Okay, so the OCT, you'll see the graft basically coming in. Okay, so once the graft basically comes in, you see it, and basically all you have to do is hold the graft into position and allow it to open, because the graft will want to open, you see, with the endothelium on the outside. And that's the natural way the DMEC tissue wants to roll. So all you have to do is just gently tap it on the surface and deepen the AC, which is opposite to when you're doing endothelium on the outside. When you shallow the AC here, you want to deepen it so you protect it from hitting the iris. And you can see already one leaf is basically open. You can tell by the orientation marker that the orientation of the graft is correct. And I just put a small bubble using a 1 ml syringe underneath the graft, and that's basically the end of the case. So the bubble is basically in the right position. You can check on the OCT now to show you the bubble is in the right position, and gently I just use a little tapping motion to move the bubble to the side to open up the rest of the graft. Okay, and then you can see the bubble underneath the DMEC tissue, and you know the bubble is basically in the right place itself. Okay, and then you can just basically put a full air tamponade in. Okay, so the positioning is basically good. So it requires less manipulation as well of chasing the graft around the eye, because you basically can put it directly in the position that you want. Once you get basically a better tamponade, I like the radial scan, like you can see on this one, so it goes all the way around, so you can see all the graft basically positioned. And then once you're happy with the position of the graft, I put a full air tamponade. I like using SF6 gas. I normally use 20% SF6 gas for basically all my tamponade cases. And then you basically get a full fill, and you can check that the graft is nicely adhered to all the way around the cornea. Okay, let's speed this along a little bit. Just see around the edge one more time. Okay, and you've got nice adherence already around the edge of the graft. You can adjust the size of the scan. I kept this at limbus to limbus size, so you can see basically all the way around, but you can adjust this to make it even smaller to just look at the graft as well. Okay, this one's a little bit more complicated case. So in this case over here, we're preserving the recipient. This patient's got a previous DSEC, and often with previous DSEC, you'll see there's a lot of basically PAS. A lot of people would do DSEC for this case because the view is not so good. But the OCT here nicely shows you all the PAS, and if you look closely on the OCT, you can actually see the descemet's membrane attached to the edge of the iris from basically the graft here. So that's why I need to basically separate this before the surgery. So this kind of real-time information is very useful when you're doing these much more complicated cases. So I'm using a reverse Sinski now to try to free up the edge of the DSEC graft. Okay, and this can often be quite sticky from all the PAS around the area, and often this will often bleed as well, which is a little more advantageous when you're doing an endothelium in procedure compared to basically endothelium out. So I'm trying to free up the edge of the graft now, trying to basically release the area of basically the PAS. And you can see the descemet's membrane now has come off from the DSEC tissue, but the DSEC actually is still stuck to the back of basically the cornea. And this is one of the issues that you can have. So having this information is quite useful because it will guide me about where I should basically put my instrument inside the eye. So I'm trying to find the area of basically the graft where I can get an edge where there's no basically PAS. Now I'm starting to coil away the previous DSEC tissue, and we often see this when I'm doing these redo cases now, where I'm taking out the DSECs and replacing them from DMECs, especially if they're slightly larger basically DSECs, because typically in DSEC, the peripheral part of the graft is basically thicker than basically the central area, and often you can get PAS around the margins over here. And being able to see this and visualize this when you're doing the surgery can help you to basically get your edge itself, and also reduce the amount of trauma you get around the iris. Okay, so now it's basically coming a little bit more, and you can see how much, but I'm having to pull away the edge of basically the DSEC tissue in order to basically find the margin and release basically the PAS. So I've stopped on the other side. I've used the reverse Sinski to go around now to have another look at where the free edges are. and then I'm trying to basically release the graft and then eventually remove it to take it out of the eye. Okay, so this is your old basically DSEK tissue. Then again, we're going to have a look now to see if there's any basically remnants of Descemet's membrane inside the eye. As Luigi said, it's important to remove these extra remnants of Descemet's membrane because it will affect the adherence, not necessarily of your DSEK tissue, but certainly if you're doing DMEK, it's going to affect the adherence of your DMEK if you have these free edges. So it's important to make sure you can remove these little small fragments because it will affect the adherence of your graft onto the back of the recipient tissue. Okay, so once we've done that, so we're going to basically insert the graft. So exactly the same technique as I showed you. So this is using the endoglide, so the 27 gauge forceps. So you pull the graft inside the eye. We don't have to worry about shallowing the anterior chamber with this technique. You can see the endoglide on the picture over here. Now the graft has basically been pulled in to the eye itself. And once you basically pull it in, you deepen the anterior chamber, not shallow it here. As you deepen the anterior chamber, you'll see that the graft will want to open up in its own formation itself. So by holding it in 27 gauge forceps, you have control. It helps you with the orientation of the graft and where the graft is going to sit in basically the anterior chamber. I'm just gently tapping to force the leaves basically open. So you can still see it's obviously still folded on the OCT. And as basically we deepen the AC, you'll see that one of the leaves will basically open up. Once one of the leaves basically will open, as the AC is basically deeper, then you can see we can put an air bubble inside the eye. So OCT can help you over here, showing you basically where the folds are. So the fold is coming around the other side. Now the fold is basically free. So once it's basically free, I'll put a 1 ml syringe of gas bubble inside the eye. And then basically, I know the gas bubble is underneath the graft itself, so the orientation is correct. So now the bubble's basically in the right place. And then by manipulating the bubble inside the anterior chamber, I can then basically move the graft across. Sometimes I will move the graft using the 27 gauge forceps so I can get it into the right position, like in this example, and then I replace the bubble, and then I'm just going to use the bubble to tap it. But this is from the inside, so from the endothelial side outwards itself. So it's being protected all the way around. And now we know we've got the graft nearly all completely open, and then we'll basically put a full tamponade in, and the graft is nicely opposed to the back of the recipient membrane. Okay, so once the graft is open, I'm just putting the iris down underneath it so it's fully open. We check again one more time on the OCT. Then we increase basically the tamponade of the gas inside the anterior chamber. So it allows you to do DMEK even in these complicated situations because you're getting real-time feedback on how basically to do the surgery. And under normal circumstances, a lot of people would probably do DSEK in this situation because they're not getting that feedback as well. Okay, so in conclusion, DMEK offers significant advantages over DSEK, but rates still around about 26 or 28%. Barriers to adoption are related to practice and experience and can significantly be shortened with intraoperative OCT to reduce complications, teach you an understanding of how to handle a thin endothelial DMEK tissue, and also basically to help you with the donor preparation and understanding the scroll configurations. All of the endothelial out techniques basically require some sort of normal anterior chamber anatomy when you're injecting them inside the eye. The endo-in techniques that I've showed you, I think, are very useful to learn because they do allow you to perform this surgery in very much more complicated situations where there's a presence of an abnormal anterior chamber. If you look at these graphs of my cases for basically DMEK, the big shift in why my numbers suddenly jumped up to over 60–70% of my cases now are all basically DMEK, really because I switched techniques from an endothelial out to an endothelial in technique. And thank you for your attention.
Thank you all for taking time off your busy schedules to join us today as well. So we have some time for questions and answers. On your screen, you notice a bar below for Q&A. Please feel free to post your questions and we'll address this on the next 10 minutes as well. So I see some questions coming in. We've got one for Professor Fatana. Good afternoon, Professor Fatana. Can I use the caliper tool under all angles and conditions in regards to the tissue because of the refractive index? Can I measure the depth of the trepanation, for example?
Yes, the answer is certainly yes. You can use the calipers in various conditions. First of all, you have to freeze the image and then use the calipers. And then you can measure the thickness of the cornea or other areas of the anterior chamber of the cornea. And and the calipers can be used to measure distances or thickness. I myself made a very, very quick comparison between the ultrasound pachymeter and the measurements of the intraoperative OCT or Leica, and I must say that I recognize that there is a good coincidence between the two measurements. So there is a quite interesting accuracy of the measurements made by the OCT as you proceeding with the operation.
Prof. George, do you want to add anything to that?
Yeah, no, I agree. I mean, the angle you can vary. I mean, I prefer the scan like Luigi showed as well, which is the radial scan, as opposed to using the square scan, because I think it gives you a good idea basically all the way around, and it's especially useful when you're doing big bubble surgery, so you know the depth that you're basically starting on. If you're doing a manual technique for your dogs, a lot of the conventional ultrasound pachymeters do not work so well if you go sub 100 microns. So this is really useful to know the depth when you're trying to get down to about 50 microns. It's not necessary, of course, every case you're going to get a big bubble. You may, if you're doing a high drops case or a complicated case, that you may leave some stroma behind. It's worthwhile knowing exactly how much stroma you're going to leave. And this is one of the advantages over using standard ultrasound pachymetry.
Thanks, Prof. So we've got one more question for you, Prof. George. So the question is, in terms of using your scan patterns, do you have a preferred or recommended size in which you recommend to extend or to contract your box, and how do you correlate this to your workflow steps as well?
Yeah, so so to start with, if you're doing a complicated case like the second case with the previous DSEC, and there's a lot of PAS and the chamber depth is shallow, then I will normally keep the scan or the radius size of the scan to be the level of the limbus itself, and that will allow you to have a really good idea of the whole 360-degree of anatomy of the anterior chamber. And I think that's really useful when you're operating on the recipient side. When you're putting the donor inside the eye, if you want to understand skull configurations and things like that, you can reduce the scan size down to probably 7.5 or 8 millimeters, depending on the size of your DMEC graft. And I think that's pretty reasonable to basically do that. And then you'll see that your angle or the size of your screen will change in relation to the size of the diameter of your radius as well. So you got to basically bear that in mind. Most of the pictures that I showed, they're actually taken with like 1,000 scans, so it's at the highest basically resolution. I don't think you necessarily need that all the time. If you want to do it quicker, you can basically reduce the resolution down to 500 scans, and that will basically give you a pretty good idea, especially if you're doing recipient preparation itself. But I mean, for purpose of illustration, I use the higher resolution just during these when I took these videos and stuff. But you can use the 500 one as well. You get a faster image itself. But I think that and for recipient, I think that's fine. But for the donor, you may want to have it for the higher scan. I think it's like similar to what Luigi said for dog. I think it's useful not only for people who are starting off DMEC, because one of the biggest barriers to adoption is having the confidence to understand which way around the graft is. You're worried about the graft flipping inside the eye. Have I got it the right way around? The orientation, how do I flip it? All this kind of stuff. But once you get more experience and you take on more complicated cases with tubes in the back, posterior chamber tubes, you've got to suture some iris and manipulating the grafts, taking out your DSECs, then you really get some understanding provided by the OCT. So I think it'll help both levels of surgeons when they're doing DMEC surgery.
Thanks, Prof. George. Professor Fontana, so back to you, the questions. Do you have a preferred number of scans which you recommend for image capture? And do you use different scan patterns, for example, the radial or the rectangular? What's your preferred size per workflow step as well?
Well, I use the radial scan, particularly for DAKs, when I introduce the instruments inside the stroma. And that is because I exactly want to follow the position of the instrument itself along the path of the stroma. I use a continuous radial scan at the end of the endothelial keratoplasty procedure to assure that the adhesion between the graft and the host is complete. And that again is very reassuring when you finish the case, to see that the adhesion between the two elements has been created quite evenly and quite completely. I must say that when I started using the OCT in general, intraoperative OCT, I was a bit skeptical about the potential advantages of the technology applied to the corneal surgery itself, as we must recognize that this technology was originally developed for retinal work rather than for corneal work. And then with the new developments, particularly provided by Leica, I must say that I now probably think the opposite. Maybe is more useful for corneal surgeons rather than for retinal surgeons, and has the precisions of the maneuvers that you can perform while you're operating on the cornea, particularly lamellar keratoplasty, is something that is very useful, not only for the beginners, but also for the more advanced surgeons.
So we've got a question coming in for Professor Jot. Are there differences in endothelial survival rates when endo out compared to endo in approach? And this is from Parvez from Southampton, UK.
Yeah, hi Parvez. So I mean, we published a large series of cases of endothelial endothelium in series, and we were getting about between 25 to 28% cell loss at 1 year, and these were pretty much normalized. Now, if I give lectures on endothelium, I like to show cases that nobody would even dare try to do with an endothelial out technique, just to prove a point, basically. And that's basically the difference. I think if you do standard cases with normal iris, I don't mind I actually flipped between the techniques for almost a year while I was using a goiter injector, and it worked fine as long as you basically have a normal iris. But as soon as you start doing cases with iris holes or aphakic cases, or things which are much more complicated, scleral fixed lenses that basically have very deep ACs and trying to shallow these eyes, then you start to really see the differences in the technique in these really more complicated cases. And I think that's the way I shifted to increasing the numbers. But I wanted to do more DMEC in these more complicated eyes, but I knew that the side effects would be less with respect to glaucoma, and rejection rate would be less, but they were very technically difficult to do if you use endo out techniques, and endo in provided a very good way and safe way of doing this kind of surgery. So I didn't have to do DSEC. So that's why my DSEC numbers have dropped. I hardly do DSEC at all these days at all. I mean, it's very rare I will do a DSEC now and stuff.
Professor Fontana, do you have any comments to that, guys?
No, I entirely agree. One question may arise whether the OCT worth the money for say general use, and I believe that nowadays it does. It is an extra benefit that you may get from a very advanced microscope like the Leica, and it does really help surgeon not only for cornea surgery itself, as you saw from Professor Mehta, pictures and vignettes, also for complicated anterior chamber procedures. So we are in an era where technology is advancing very rapidly and is coming to the help of the surgeons, particularly for performing not just straightforward cases, but particularly complicated cases. So I believe that nowadays an OCT attached to a microscope is going to be more and more a reality rather than an exception.
Thanks, Professor Luigi. So last question from our side. I see a question here. How does the resolution of your Leica OCT compare to the other intraoperative OCT systems in the market? Professor Fontana.
This is a question for you, Alvin.
I'll take this. So the actual resolution here is, I have to admit, if you guys haven't seen the product, I would highly recommend a demo in the OT. It's resolution in the cellular level, so we get to 2.4 micrometers. And I think in terms of scan density, it goes up to 500 and 1000 B scans. And in doing so, you're basically imaging in between the lines as well. You're imaging the entire spectrum, and this gives you greater confidence in your clinical decision. So I think in terms of resolution, in terms of scan density, and also in terms of the caliper features, I highly recommend to at least try it out. All right, so I think we have reached the end of the webinar. Thank you, Professor John Metzer, and thank you, Professor Luigi Fontana, for your time, and thank you everyone for attending this webinar as well. If you have any questions or if you need any resources, please feel free to reach out directly to us. You can reach out to the library on the screen as well, or contact us directly. And again, thank you for joining us today, and all the best, take care, and we hope to see you again very soon. Thank you.
Thank you.